Hi, good afternoon. My name is Jeanmarie Perrone, and I'm an emergency physician at the Hospital of the University of Pennsylvania. I wanted to tell you about our program called the Center for Opioid Recovery and Engagement, or CORE, increasing treatment for patients with opioid use disorder in the emergency department, the evolution of a peer-led model. Thanks to the Healthcare Improvement Foundation for this honor to share our work. One of our goals is to disseminate our work throughout the region, so this is really helpful to us. This work came out of a tremendous need in Philadelphia. Philadelphia has the highest overdose death rate of any large city in the United States, almost 3 times the size of, almost 3 times the rate of New York City. We know that the critical part of our program is our peer recovery specialists or certified recovery specialists. Here pictured are Nicole O'Donnell and Bryant Rivera with one of our long-term patients. We have a third recovery specialist, Kelly Marie Garant, who is also another one of our team members. Their work has been critical to integrating the care of patients in our emergency departments. In 2018, we saw 2,000 patients with opioid use disorder in the EDs in our 3 downtown emergency departments. So there was a pressing need to create a program that would allow us to connect those patients to treatment. The key barriers, Davis?
Sure. So my name's Davis Herman. I'm a design strategist at the Center for Healthcare Innovation, and I had the pleasure of working with Nicole and Dr. Perrone and others on this project. And when I got involved in 2018, one of the first things we did is we looked at some of the key barriers, the things that were getting in the way of using our best tools in combating the opioid crisis, namely medication and peer recovery specialists. And so we identified barriers that fell into 3 buckets. The first being patients with opioid use disorder were not readily being identified when they presented to our hospitals. The second was that we were missing opportunities to use some of our best treatments like medication. And third, we were failing sometimes to link patients to adequate long-term care. So we began with identification because we knew that would sort of be the foundation for everything else that we did. And we began that work with a hypothesis that if we were to set up a more proactive way of identifying patients, we could significantly increase the involvement of our peers. We knew that historically we were asking ED physicians and other clinicians to call us when patients with opioid use disorder presented to the ED, and that manual step was sometimes being forgotten or missed. And so to test that hypothesis, we did a very quick pilot where I reviewed in the health record, the ED board every 2 hours. And if I saw a patient who I thought maybe would benefit from a peer recovery specialist, I let our recovery specialists know about that patient. And we found early on that we were identifying far more patients, but the issue was that it wasn't scalable. You know, I had to sleep at some time, so we had to find a new way of doing it. And so if you want to go to the next slide, you'll see a screenshot or an image of our automated solution. So we took everything we learned in that pilot and we baked it into a system that monitors our 3 downtown hospitals. And when patients meet certain criteria, a secure message is pushed out to our peers who can then jump into action to talk to that patient, to call the clinician for treating that patient. You know, the next steps kind of vary depending on the need. It was a very successful sort of move to automation. It runs 24/7, it takes no work. And we've iterated on this at least 8 times to date.
So our work includes the peers who have the conversations with the patients initially. And then really the most important aspect of what we were missing was getting patients into medication treatment. This is not an inpatient hospitalization. This is starting them on the medication called buprenorphine. Buprenorphine's success in keeping people in treatment and preventing overdose deaths is dramatically higher than inpatient rehab or detoxification. 60 to 80% of patients who are on buprenorphine it's a decrease in overdose death rates. Next slide, please. There's been a landmark trial about 5 years ago published in JAMA by colleagues at Yale who demonstrated that the ED was a very good place to start people on buprenorphine. And they were able to demonstrate that if a patient received their first dose of buprenorphine in the emergency department, twice as many of those patients were still engaged in treatment at 30 days compared to patients who were just received a referral alone if they were coming into the emergency department looking for treatment. Next slide. Today, one of the barriers that we've overcome is that in order to write a prescription to get a patient started on buprenorphine, we need to have the clinician take an 8-hour training program. So initially when we started this, there were just a few clinical champions who had their X waiver. Through an incentive program, we were able to get almost 90% of our clinicians X waivered. And so now any clinician working in our emergency department can write a prescription for a patient. So the patient is met with the peer, they get their first dose of buprenorphine, and then they also get a prescription. And then the peers step in the next day to get them to their follow-up appointment or in the next few days to make sure that they're doing okay on the new medication and to help facilitate their next steps in treatment. And that continuation in treatment goes on for up to a year. Next slide. Nicole.
I am Nicole O'Donnell, a certified recovery specialist who meets our patients bedside in the emergency department. What we did want to create was some social norming with our ED providers and some good energy around them getting their X waivers and being able to write buprenorphine prescriptions for our patients that were started on the medication in the emergency department. And we wanted to create some positive feedback for them. So Davis created the Bupe Fairy, and we would give high fives for providers who gave patients buprenorphine in the emergency department. We also wanted to create some energy around harm reduction strategies, specifically around Narcan, throughout the health system and the community. Next slide. We have increased our CRS consults. I mean, as you can see, for a year there were 27, and August of last year, three certified recovery specialists have seen 450 patients. Next slide. At scale, we're looking to have 9 certified recovery specialists throughout the Penn Medicine Health System and 3 care coordinators. Which means the timely identification of patients, getting more patients into treatment 24/7, supporting all the providers throughout the health system, both the hospitalists, which are on our medicine units, and in the emergency department, which means more linkage to care for patients seeking treatment. We have successfully onboarded our 3rd CRS in October of 2019, which has increased our engagement with patients at Pennsylvania Hospital and the Crisis Response Center over at Pennsylvania Hospital. And we increased access at the CRC and did outreach there for patients that present for inpatient treatment to engage in medication for opioid use disorder.
Thank you.